Thank you everyone for being here. I would like to call the meeting to order of the Committee to Study Long-Term Managed Care. The first order of business is to review and approve meetings from the previous minutes from the previous meeting. Sorry, not enough coffee this morning or too much. Do we have a motion?
Yeah, I move we accept the minutes from the previous meeting.
I do have a comment, Mr.
Okay.
Chair. Actually, the first paragraph of the minutes from September the 15th is the first paragraph from our organizational meeting. So I need to read the actual first paragraph that we should have. The rest of the minutes are fine.
Okay.
The first paragraph should read, committee was called to order at 1:31 p.m. by Chairman Kofold, who announced the committee will meet again on Wednesday, September the 24th at 2 p.m. and Monday, September the 29th at 10 a.m. Minutes from the previous meeting on September 12th, 2025, having been reviewed by the committee members, were approved.
All right. Thank you. Any further changes, further discussion?
None for me.
All right. All in favor of approving the minutes as amended?
Aye.
Aye.
All opposed? And abstentions. All right. The minutes are approved. Next item on our agenda was to hear from somebody from Granite Case Management. She emailed me and informed me that she would not be able to attend today's meeting. So I think what I have done, and I've already given Mr. Lippman kind of a heads up and my fellow committee members, is as somebody who probably knows considerably less about Medicaid than many of the people in the room, I really was trying to get my head around the key issues and some questions and things like that. So I'm going to ask Mr. Lippman to come forward, and what I'm really looking to do is to lay out the facts as I have come to understand them. I'll invite the other committee members to chime in, ask questions, or provide additional input at any time. But I'm really looking for validation of, is my understanding correct? And then there are a number of questions along the way. After that, I will invite anybody else who is in the room who wishes to chime in if you feel like there's a critical point that we've missed, or if you feel like there's another answer to the question that you feel you'd like to expand on. We can hear from those folks towards the end of the meeting. I know Mr. Lippman has a deadline here to get to another event. The final thing I'll say, just for everybody's information, is that our report is due next week, October 1st. We do have a meeting scheduled for the 29th. What I think we are going to end up doing is issuing a preliminary report for October 1st, and we will continue with a couple of meetings after that. I think there are some unanswered questions that perhaps none of us know the answer to around the One Big Beautiful Bill, and I think there's going to be some additional discussions probably that we need to have before we can actually make recommendations as a committee. But we will have a preliminary report, which I think will lay out the key issues and just frame the overall topic as a preliminary report. So with that, I guess I wanted to start sort of laying out what I think the impact is on nursing homes, or my understanding of how the system currently works with respect to funding to nursing homes. So the Medicaid rate to counties ranges from, looks like $247 a day up to $290, and higher acuity patients are as much as $342 per day. But actual costs tend to exceed that, so that's where ProShare and MQuick are helpful in essentially taking money coming from the county to the state via intergovernmental transfer, being matched by federal dollars, and then being returned to the nursing homes, providing an additional $100 to $150 a day per patient, approximately, and a total of $60 to $70 million a year for the county nursing homes statewide.
The only thing I would validate there is that the ProShare only goes to the county, not the other nursing home.
Understood.
MQIP goes to both.
Thank you. Yes, understood. So and then there's MQIP, includes private nursing homes, is a supplemental pool that rewards quality, adds an average of the $74 a day for counties and private nursing homes, total being about $100 million annually.
Yes, and the other thing I would add there is that similar to ProShare, both the counties and the privates pay a tax that's known as the NFQA, similar to the Met.
Yep, and then that's matched by federal dollars in return. Okay, so and this is where I had a question, because well, I have a number of questions, because there's been sort of a statement, or I was under the impression that those payments would be phased out under the One Big Beautiful Bill. And what I understand instead is that any excess above the Medicare rate would be phased out over a period of 10 years. So if the base rate plus ProShare, MQIP, anything else exceeds the Medicare rate, which is about $550 a day, then whatever excess is there would be reduced by 10% each year until it's gone between 2027 or between 2028 and 2037. So my conclusion there is I'm not sure that phase out necessarily affects ProShare and MQIP at all in New Hampshire.
In terms of the tax that is collected, it does not affect that. The payments for ProShare have always been limited to what they describe as a Medicare cost equivalent, and because privates only pay the MQIP component, there's really not been a factor that they've been paid more than Medicare. So I think your conclusion that OB3 is not going to affect that program is correct.
Okay, and then there's a kind of a different question around intergovernmental transfers, and whether or not intergovernmental transfers are to be phased out or eliminated under OB3, and I don't have an answer to that, and I don't know if you do.
In terms of the nursing facilities, I think we're good in terms of where we are. I think the question that was raised during testimony is, if we change to a managed care system, how would those things be affected?
And that's a separate.
Yes.
That's a separate question. So, in one of the documents, and I'll just quote from one of those documents: supplemental payments are expressly prohibited by CMS under managed care Medicaid systems. So, does that mean that ProShare and MQIP are necessarily eliminated under a managed care system? And that has been my understanding so far, but is that necessarily true?
I think I guess the short answer is that under a managed care system, payments in excess of what the regular rate would have to be approved in some form of waiver.
Okay.
And what that would look like and whether it would be approved are question marks.
Okay. So, but I understand Texas has, and I still have yet to research the Texas system, but I understand Texas has been using that kind of a model, and they've been doing it for some time with the CMS waivers in place.
That's true. Waivers are typically a 5-year window, and CMS, with changes in administration, sometimes they extend them and sometimes they don't.
Okay.
And so you couldn't say with certainty that it would be, but it's also fair to say that based on Texas experience, that something is possible.
Okay, so it creates uncertainty, is I guess the key
a little
takeaway there.
Uncertainty, and I think at a provider specific level, depending on the program, it may create more uncertainty than what they usually have under ProShare and the MQIP payments.
Okay. Any questions? Okay. I think the next section in my notes here are, I think I've already asked those. It's about state directed payments and the phase out under OB3. So let's talk about dual eligibility. So 31,000 dual eligibles in New Hampshire, tending to have more complex needs, often multiple chronic conditions or behavioral issues. So the DSNP proposal, or what we saw from the last meeting, sort of lays out a plan for rolling out DSNP and potentially PACE, one or the other or both, but DSNP kind of seems to be the foundational piece of that. And so this is something that it sounds like DHHS envisions could include a role for MCOs in sort of operating as the Medicare Advantage provider in those cases. Is that?
That's correct.
Okay.
We've included in our managed care contract a provision from the state to have that right for DSNP, and from an efficiency standpoint, having the insurer be the same both under Medicaid and Medicare would result in a much better coordination and better spend than having two different insurers kind of deciding who's covering what.
Okay. And then as far as PACE is concerned, wasn't necessarily clear whether this slide deck that we got last time was sort of leaning heavily on. It sounded like it was more focused on DSNP and less focused on PACE, and the PACE would be feasible only in the more populated areas of the state, or would be more practicable in more populated areas of the state. But I'm trying to get a read on, is that something that DHHS envisions a high likelihood of rolling out with DSNP, or an afterthought, maybe not. I'm just trying to get a sense of sort of what the temperature is on that one.
So I think that what we heard in testimony from the county, Hillsborough County in particular, and I think Stratford County, those have been the two that have had the most kind of interest in that certain things would have to come into play to make that feasible for them to do. And I think it's certainly a potential, but I think it would take more examination on the part of the counties and the part of the state to look at that, whereas DSNP I think is a more straightforward thing, as long as there are MCOs that have Medicare Advantage plans in place. And it's not a short-term thing. There's a sort of a specific calendar that's in place. The earliest that calendar could be exercised would be in 28, because there are certain notices that the parties have to give to CMS to let them know what's happening. And I think I'd raised in my testimony the concern about some of the existing Medicare Advantage plans pulling out. That may mean there's more opportunity, but would be some time for the MCOs to stand something like that back up with CMS.
Okay. And then as far as PACE is concerned, it sounds like you were saying that you would envision the counties stepping into that role as PACE organizations, or would it be a mix of counties, potentially others?
I think that as under the current financing structure, how we finance long-term care, they would be the most logical party to be involved in that, because as a lead, I think certainly there'd be a partnership with the state in that, but I think that neither could do it on their own based on the financing structure today, potentially, and without some initial seed funding to get something off the ground. I think David Ross is here, who testified to that.
Yes. Okay. So I think I missed a joke there.
Big seeds.
So one of the charges of this committee also is to look at ways to obtain enhanced federal funding. And so, I guess, one of the things that comes up there is presumptive eligibility, which sounds like it prevents the need for somebody to go directly into a nursing facility that can start getting care right away and not sort of wait for the whole approval process to complete first.
If I could,
Yes.
so under the OB3 bill, there's a new presumptive eligibility component that was identified. Guidance on it has not come out to states yet on it, but the big difference in it is that it would allow individuals who do not meet an institutional level of care, which our current presumptive eligibility in all states requires that you meet an institutional level of care before you can get services. This would make that a bit easier to qualify for services. Presumptive eligibility, the state has a waiver request into CMS that we're hoping we'll hear any month now on whether they approve it. It's modeled a lot after like Washington State has, where we could, someone who we believe has a reasonable chance to become eligible, that we could institute services for a period of time, not institutional services, but home and community-based type services, to make sure that they don't decompensate to the point where they need an institution while they're waiting for their Medicaid application to be approved.
And then this one was new to me. Tell me a little bit about Money Follows the Person, sort of transitioning people from facilities back to the community. Is that?
Yes. So this, the state has received an additional grant award to go above and beyond sort of the usual set of benefits someone has to get them back from an institutional-based setting to the community-based setting. It might include something like move-in costs and certain things that wouldn't ordinarily be covered under a Medicaid waiver that would allow for that person to leave the institutional setting to be back in the community.
Okay. Another area that we're to look at is streamlining Medicaid eligibility for consumer choice and less restrictive environments. So we already talked about presumptive eligibility. I think most of this stuff is the department's already done these things. Online simplified applications, forgetting the no wrong door. Is that there was another thing I didn't make it in my keep it in my notes, but there sort of that people have multiple points of entry into the system. Person-centered planning, prioritizing assessments based on preference, and expanded HCBS slots, which it sounds like we're not using. We don't have a wait list. We haven't maxed out our HCBS slots as it is under the current waiver. So it seems like the department's doing everything that it could potentially be doing in that area at this point.
I think we have an initiative in every area that you talked about. I think we are planning to do better. The legislature also gave us an HB2 $3 million. Thank you to the nursing facilities that are willing to allow the licensing fee to go up to invest in some workforce temporarily to help us catch up from the situation that the pandemic and workforce freezes that affected us. But we've made investments in technology and process that are still underway, and they haven't fully been realized. We do have a reporting responsibility, I think in January the first time, to give updates to, I believe, fiscal committee and HH's oversight. But we need to work further, and we've been partnering with the nursing facilities and CFI agencies and others to work through some of the things to make it better.
Okay. Any questions or comments?
None at this time.
Okay. I guess the last item on my list is sort of, as we've had a discussion, there's been a number of comments about sort of which populations might we address with long-term managed care support services. And broadly speaking, those were identified as the DD, ABD community, and then elderly, sort of nursing people elderly people. I guess one of the things that I researched and looked into a little bit was whether there is the potential to carve out HCBS as a distinct population, distinct from nursing facility population, so that we're treating one HCBS under managed care and nursing facilities under a traditional fee-for-service model. And my understanding is that that would potentially preserve the ProShare MQIP model, and that it could, and I guess in New York, Pennsylvania, and Wisconsin are the three states that I think are doing that or something similar to that. I guess I'm just interested in hearing your thoughts on that as a potential path forward. So we're talking, elderly. I think so far there seems to be an inclination to not try to do everything, and to not do DD, ABD. But even within the elderly community, it seems like there's potential to divide that into these two populations. So I'm interested in hearing your thoughts on that.
So I do think in terms of stratifying the population, the ones I think we testified to is states tended not to do. Some states went all in and did everyone at once, and that's been a challenge. I think the DD, developmentally disability community, and acquired brain disorder, in-home supports, those have been sort of typically in prior plans have been left to success in the earlier phase. I guess with the HCBS population, one question I would have for the MCOs is if we're talking today about a 3,600 person population, is that sufficient enough from a business perspective to work? And I guess in terms of, I'm not sure whether that would require a specific waiver or not, but that would be my fundamental question: is there enough of for them to make the investments to have it work the way we want it to work?
Okay, so potentially not sufficient economies of scale to make that work.
I think I'm not sure I have the full answer to that because
Right.
I've never asked them that question, but that would be what would be lifted up for me in terms of that's a relatively small population.
Okay. Is there anything that so again, this is me trying to just get my head around the
You've done a great
key issues. Is there anything that you think I've missed that you feel like the committee needs to understand or be aware of?
I think in terms of the transition for HCBS, whether it was with other populations or alone, I think there is an established network of home and community-based CFI case managers, and I think that was the testimony that wasn't able to be provided today. I think from past experience, I would suggest they probably wouldn't be in favor, and they would be trying to find their role in that process. That's the only insights I can give you on that.
Okay. All right. So
I'll be here, and if
thank you very much.
there are
Appreciate
questions
that.
that come up afterwards that you want to ask, please reach out.
Okay, appreciate that. So I know we have folks here from the Association of Counties. We have folks here from some of the MCOs and from the Granite State Healthcare Association. So I guess I want to sort of invite if there's anything you'd like to comment on that we've talked about so far, because I've thrown out a couple of ideas or a couple of topics that I found in my research that have not necessarily been discussed previously, but I'm curious if anybody in the room wants to come forward and offer comment, fill in gaps if there's anything that I've missed that you think is important to inform the committee of. Yes, Mr. Ross.
Thank you, and for the record, just David Ross from Hillsborough County. I would just echo Mr. Lippman's comments that if the counties were to take a role in either PACE or DSNP oversight, there would be a lot of vetting that would be required, and both taking a look at both the infrastructure that was required from the counties and for the capital investment and financial investments that are going to be necessary to see those programs. This is all very preliminary discussion, and I think that there's a lot of vetting that has to be done. So I think a timeline would be an important consideration for further discussion. Thank you.
Thank you. And I'll just ask Mr. Lippman, I'm not real familiar with the parameters around the Rural Health Transformation Fund. Would that be potentially an appropriate mechanism, or appropriate place to spend that money to ramp up in a program like this?
There could, as I understand the criteria, that there could be investment in assessing the process in terms of making like regular payments, no, but to do sort of like feasibility work to look at throughput in the healthcare system. I think that's really kind of the angle that fits in the grant, that getting people to the right level of care. Particularly in the rural environments, we heard that from one of our public forums, about the future of one of the nursing homes in Coos County, questioned how long that building can remain open given its age and repair as an example. But I think in terms of looking at some of these topics, it seems like some of it could fit into sort of evaluation and sort of some seed kind of funding.
I know that the rural transformation funds can't be used for direct reimbursement. Can they be used, as you mentioned, the seed fund, but in terms of the nursing home situation in Coos County, could it be used to remodel, for example, or upgrade that building to make it useful for another decade or two?
So construction is a prohibited expense other than sort of incidental to like a minor renovation to accommodate like an equipment or a new service, not a sort of a wholesale multi-million-dollar kind of construction project. I do think that where it does fit in is, for example, that strengthening the workforce in home and community-based services, like people going into the home care nurses, the mobile MIT mobile health integration, MHI rather, or MIH. Mobile integrated health is what I was trying to get to. Mobile integrated health is where people like paramedics or EMTs go to the home and check in on people and can do assessments to make sure that people are doing okay in the home. So I think in terms of strengthening the base of community supports is consistent. I think in terms of clinical ladders, in terms of people who might be medical assistants, becoming an LNA, becoming a LPN, becoming an RN, all those things definitely fit within the Rural Health Transformation Program. And also could be telemedicine to support provider services in the nursing facilities as well.
Okay.
None at this time, thank you.
All right, thank you. All right, is there anybody else who wants to offer their thoughts on some of what we discussed, including the sort of the HCBS carve out or other alternatives? All right, we'll have a short meeting today then. So, so I think what we are going to do is I'm going to be drafting a report, sharing that with the members of the committee between now and the next meeting, and that is primarily going to be laying out the issues. What are the key issues and concerns? It will not include recommendations at this point. It may mention some potential alternatives and the pros and cons of some of those alternatives. But as I said, I think there's, I know I still have some unanswered questions about OB3 and the impact that that could have on all of this, as well as needing to understand some of what the other states have done with respect to managed care and sort of managing things like quality incentive payments and how they've structured those to make it work in their states, and whether or not that could work in New Hampshire. So with that, I'll ask if there are any final comments or questions from the committee. Last call, and with that, we will adjourn the meeting. So thank you everybody for being here.
Thank you.